Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaj. Um, Thank you, Dr. Mithuna, for giving a little company in the combined study for the
Thank
preparation.
thank you for having me, sir.
We still have recently we uploaded all the older videos and PowerPoints of 2000 to 2015 in the web we have uploaded. I will also get an activation done for you freely of that in the scoreapp.in, right? So there you have all the discussions by various teachers, not just the boring face of Dr. Murali Bharadwaj, but different teachers are there. Some are good, some are excellent, some are boring. Whatever it is, try to revise and there are few sessions 2018 paper, 2021, 22 INICET papers. There are 7 8 papers that we need to discuss, recent 7 8 years papers may that we will do that before 7th, right? So that is the plan. So nice to see Meghasvana and many more. Can the online students can punch? Is the voice loud and clear for all of you, doctor? Now, blunt abdominal trauma is one of the favorite topics of the examiner. Already we finished around 254 questions. There are around 500 questions. We are half the way. Remaining topics are all very minor topics, so which we will try to finish. Meghasvana and everybody, can you please punch? Is the voice loud and clear for all of you? Thank you, Meghasvana. Now, a man comes to emergency with stab injury in the left flank. He has vital stable. What is the next line of management? Mithuna?
CECT, sir.
Very good. So, whenever there's any stab injury to the flank, CECT will assess the extent and severity of injury and kidney, spleen, etc. Is there any need of surgery or not? Many information you can get from CECT. Blunt injury abdomen patient is hemodynamically stable. What is your next investigation?
F FAST, sir.
It is FAST, fast. So
Focus
focus
assisted
abdominal
sonographical
tra-
assessment of assisted sonographical assessment by trauma for trauma,
yeah.
something like that.
So focused assessment with sonography for trauma fast is a non-invasive rapid ultrasound examination. Now, what is the commonest organ injured in blast injury?
Lung. So I thought, sir, if it is given as eardrum, I think that's the most commonest, right, sir?
See, the point is organ, that's all.
Hmm.
And that is lung, which is
Lung.
airfield,
Elf,
basically.
yes, sir.
In blunt trauma abdomen, what is the approach for laparotomy?
Always midline, sir.
Always midline is one answer and depends on the organ injured also. So the approach should depend on the organ that is injured also. So after road traffic accident, there is a non-pulsatile retroperitoneal hematoma. On-table IVU was done. Right kidney not visualized. Left kidney showed immediate excretion of the dye. So what is your management?
You'll perform on-table angiography.
Very good. So uh, on-table angiography. So whenever there is any non-pulsatile retroperitoneal hematoma with road traffic accident, IVU is showing non-visualized right kidney and immediate excretion from left kidney. You need to know what is the source of bleeding. That's the reason you need to perform on-table angiography, which is minimally invasive diagnostic technique that will enable you to know what is the source of bleeding whenever there is any retroperitoneal hematoma is what you need to remember. So fast stands for
Focused assessment with sonography for trauma.
Very good. Now, with regard to Ogilvie's syndrome, what is accept about it?
It is not caused by a mechanical obstruction. So A is the answer.
Correct. So it involves the entire part of the large colon. It is called pseudo obstruction. It occurs after previous surgery. It occurs commonly with narcotic usage, where there is a massive dilatation of the cecum and the colon without a mechanical obstruction is called Ogilvie's syndrome, is what you should remember, doctor. So
Yes.
nice to see Dr. Sagar Mehta, Meghaswara, 9 more, even though it is 10 o'clock. There is no time when we are maniac to become a winner. So whenever possible, we'll try to have 1 or 2 sessions also, because there is no travel time involved, both for the teacher and student. But generally 1.5 hour maximum, petrol khatam, in the online class. If it is an offline class, we can sit for 3, 4 hours also. Right? Am I right, Dr. Mithuna?
Yeah, sir. Yeah, sir.
Online means 1.5 hour. That too, if 2, 3 students are sitting and teacher is there, 1.5 hour. One student, one teacher is there means maximum 1 hour. लाइव क्लास बोले तो बहुत ज्यादा बैठ सकते. So Wujma Sadia is asking, sir, who is Mithuna? This is a good MCQ. Mithuna is an aspirant like you who is also preparing, but join the session in order to um, give a bit company to all of you, that it is not just teacher's monologue, rather there is a dialogue of a student and teacher. Guru Sishya Parampara. Huh? So if any of you want to join the broadcast, please directly message me on the WhatsApp, doctor. Right? So I'll be more than happy to invite you on the broadcast so that it will be interesting for you. A newborn girl not passed meconium for 48 hours has abdominal distension, vomiting. What is the initial investigation?
This is meconium ileus in the newborn, and among the options, it is lower GI contrast study, sir.
Very good. So, in a newborn girl, symptoms of abdominal distension, vomiting, not passed meconium for 48 hours, always you should do a lower GI contrast to visualize the colon and rectum. It can enable
So,
you to know what is the cause of this obstruction, whether it
so
is.
why not? If X-ray is also given, what do we choose in comparison to this and X-ray? Because I did a little research on this topic, sir, and everywhere it's mentioned that it's X-ray abdomen, it's X-ray abdomen. So,
See, the point is, if you are doing a GI contrast study, it will help you to identify a ganglionic and a ganglionic segment, which is one is constricted,
Hirschsprung,
other is dilated. You
Hirschsprung,
can
yes, sir.
look at the what you call transition point. All this can be known by doing lower GI contrast study. That is a funda.
Okay.
Yeah, yeah. So very good, doctor. Good to see 12 online classmates. Now, a child presents with recurrent abdominal pain, bilious vomiting, and condition was diagnosed by barium follow through. Surgery was done, mesenteric widening is there, appendicectomy, cutting the latch band. So, all this will give you a clue of.
Malrotation of the gut. Latch
Correct.
band is nothing but the fibrous band which has caused malrotation. So,
Correct. So latch band congenitally led to the development of mall rotation, and mall rotation is typically presents with bilious vomiting and recurrent abdominal pain is what you need to remember. The cecum is found to be placed below the stomach in the midline, which abnormality has taken place while rotation of the gut happened.
it's the malrotation again, sir.
It's called mall rotation once more. So post-operative ileus maximum in.
Uh, in colon,
It is maximum in colon. Now, radiological features of intestinal obstruction. So, the small intestines are said to be dilated if the loops are more than 3 centimeter in diameter. Volvulus in mesenteric ischemia, typically in volvulus you have coffee bean sign. Mesenteric ischemia, there is a thumb print sign. So typically they have their own characteristic signs on abdominal film. The absence of air fluid levels does not rule out the presence of obstruction. That is also true. Now, small intestines are said to be dilated if the diameter is typically more than 3 centimeters. The large bowel is said to be dilated. The criteria are not very sure for the large bowel as much as the criteria is there for small intestine. That's the point you need to remember. Generally, a diameter greater than 6 centimeters, if it is transverse colon, or greater than 9 centimeters in cecum, then it is considered to be abnormal in case of large bowel. But generally, the diameter criteria to define dilatation is not as clear in large bowel as it is clear in the small intestine. That's a point you need to basically remember. Now comes oral cancer. 32-year-old female from the rural background presented with the history of chronic tobacco chewing, difficulty to open the mouth. Johnny,
This is
Johnny, yes, Papa, eating sugar, no, Papa. Open the mouth, no, Papa. I'm having submucous oral
submucous oral
fibrosis.
fibrosis,
Now,
premalignant lesion for oral carcinoma.
with carcinoma tongue found to have lymph node in the lower neck, what is the treatment of choice, doctor?
Radical neck dissection, sir.
More than lower cervical neck dissection, radical neck dissection. So radical neck dissection is considered the treatment in the lower neck in the patient. Whenever the lymph node in the lower neck in a patient with cancer of the tongue, depending on the extent of lymph node involvement, the stage of the primary tumor, and radical, it is radical. What is radical about it? It removes all the lymph nodes in the neck, as well as the internal jugular vein, spinal accessory nerve, sternocleidomastoid, right? So that is the reason it is very radical. But if the tumor is more limited, it's not a very late tumor stage, then you can use lower cervical neck dissection, is what you need to understand. Now, a patient presented with 1 into 1.5 centimeter growth along the lateral border of the tongue. So, what is the treatment, doctor?
Small soul laser ablation.
Laser ablation. Laser ablation is very minimally invasive technique, doctor. You use a laser beam and destroy. For the early stage tumors of the tongue, particularly along the lateral border, because it will allow the precise removal of the lesion while preserving the normal tissue function. That's what you need to remember. So, interstitial brachytherapy, external beam radiotherapy, they're all the ones which are using high energy radiation, typically for larger tumors. Advanced stage tumors, you require interstitial brachytherapy and external beam radiotherapy. Now, what is most beneficial? Using chemotherapy with a course of radiotherapy, do you want to give it as a neoadjuvant, concurrent, or adjuvant, or alternating with chemo and radio?
Concurrent.
So
Together.
it is concurrently. So concurrently means you are
Together, sir.
preparing for the high yield fats and taking mock tests also. Like that, chemotherapy with radiotherapy, whenever you do know, that's called concurrent chemotherapy, usually given weekly or bi-weekly. And it is given sequentially, alternating with chemo and radio, and that will improve the local control and reduce the risk of distant metastasis is what you need to remember. This is one dirty question, doctor. Very difficult to master, right? But still, dirty things we need to be more dirtier to remember them. There is no other option, right? So now the question comes. Patient has carcinoma tongue, right lateral aspect, lymph node 4 centimeter, size in level 3 on the left side of the neck. What is the stage?
N2.
N2. So how it is N2? The T stage. Don't forget these criteria. T1 means less than 2. T2 is 2 to 4. T3 is more than 4. T4 is invading adjacent structures. You'll remember for the exam, right? So 2 is 2 to 4. 1 is less than 2. 3 is more than 4.
4.
Now, coming to the N stage. N2, N1 is metastasis to single ipsilateral lymph node less than 3 centimeters in greater dimension. In N2, you have N2A, N2B, N2C. N2A means metastasis to single ipsilateral lymph node more than 3 centimeters but less than 6 centimeters. Metastasis to multiple ipsilateral lymph nodes, none more than 6 centimeters in greatest dimension is N2B. N2C is metastasis in bilateral or contralateral lymph nodes, none more than 6 centimeters in diameter. N3 is a lymph node more than 6 centimeters in diameter. So in the given patient, what do you have on the right lateral aspect? There is a T2 to T3 tumor and presence of 4 centimeter lymph node in level 3 on the left side of the neck indicate regional lymph node involvement which corresponds to N2 stage. So that is how N
Contralateral.
become the option. So please don't forget, this is purely bhatti item. There is no intelligence, nothing required, right? But you need to mug it, just like endometrial carcinoma staging, cervical carcinoma staging, ovarian carcinoma staging. You need to mug it up. And let me tell you, no teacher can help you to mug the things. Mugging is your job, right? Digging the concepts is my job, right? So let us clear it, test it, deliver it, right? That's the plan. So, doctor, in which head and neck cancers is lymph node metastasis least common?
Hard palate. Bony.
Heart palate. So the risk of lymph node metastasis varies according to the location, right? Now, coming to pancreatitis. A chronic alcoholic, sudden onset of epigastric pain radiates to the back, and the patient will typically tell, whenever I am lying down, doctor, the pain is more, he will say. Because pancreas is a retroperitoneal
Oh
component is
God.
there. So whenever he lies down, then it will be touching the spine and pain will be more. So typically increased LDH,
Because high
hypocalcemia,
serum lipase.
correct.
High
So
lipase, high
serum lipase
amylase.
is high. Now, doctor, with reference to pancreatitis, तीन बट्टे मारने वाला आइटम्स है डॉक्टर. ग्लासगो स्केल, एपची स्केल, सीटी सिविरिटी इंडेक्स. सो हर एक के बारे में एक मर्तबा बात करेंगे. ग्लासगो स्कोर. ग्लासगो इज नॉट ओनली फॉर कोमा, neurological status. There is also a Glasgow for
Pancreatitis.
pancreatitis. So, what are the criteria in the Glasgow, doctor? Age, body mass index, serum level of several biomarkers, systemic inflammatory response syndrome. It will be 0 to 15, 0 to 2 mild, 3 to 4 moderate, 5 or higher, severe is what you need to remember. Apache 2, what are the criteria? Blood pressure, heart rate, respiratory rate, oxygenation, electrolyte balance, neurological status, they're all components of Apache 2 score. And it comes 0 to 4, 5 to 9, 10 to 14, etc., etc. That will predict the mortality rate. Then, before the CT is the best investigation to know the severity. It will let you know whether the pancreas is involved less than one third, more than one two thirds, or one third to two thirds. Any peripancreatic collections are there. What is the spread of necrosis? Any pseudocyst of pancreas developed? All this information you get in CT severity index, so it is a gold standard. So, pancreatic inflammation, extent of pancreatic necrosis, any fluid collections, abscess, pseudocyst, everything. So, accordingly, you have 0, 1, 2, 3, 4, 2, 6, 7, or higher is what you need to remember. This is the most interesting question, doctor, which is not a prognostic factor in acute pancreatitis.
Increase serum amylase.
Generally, high amylase is indicative of pancreatitis.
Pancreatitis.
But it is not the part of Ranson's criteria. That is a paradox. A lot of students do mistake of this question.
So we had
Apply-
discussed this before, right? It's
Correct.
used. It stays for a very long time, even after the resolution of the inflammation. Amylase and lipase stays more longer than amylase.
Lipase is more specific. It
Specific,
has
yeah.
very less number of reasons than acute pancreatitis. Whereas amylase elevation has many causes, and even if it rises, it is not the criteria. So, what are the criteria to prognosticate? Typically, Ranson's criteria are at admission and at 48 hours. A score of 3 or more indicates severe pancreatitis with mortality up to 15%. And age, WBC, blood glucose, serum LDH, AST, calcium levels, that is hypocalcemia, PaO2 less than 60, base deficit more than 4, BUN more than 20, and hematocrit more than 10%. You should not forget, doctor. You need to revise this. Now, the most common complication after ERCP, what is that, doctor?
Acute pancreatitis.
Very good. It is acute pancreatitis. Now, severity of the acute pancreatitis correlates with all except
Amylase.
amylase, which does not correlate. Once more, a repeated question.
Serum amylase, yes.
Now, non-progressive contraction of the esophagus. So, fundamentally, esophageal contractions are primary, secondary, tertiary, quaternary. So, non-progressive or tertiary. A female has dysphagia, intermittent epigastric pain, esophagus is dilated, narrow in the bottom. That's called rat tail
Heller's,
appearance.
Heller's
you-
cardiomyotom.
So, what is your diagnosis?
This is echolalia, sir.
So, in echolalia, what you do? Dilatation.
Dilatation. Okay.
So, you will pass a bougie, esophageal bougie of dilata, and dilate the distal end of the esophagus is what you need to remember. Young
So
patient
Heller's
has
is for?
dysphagia. More to liquids than solids. What is your investigation, doc?
You'll do a barium swallow.
So, always remember, if at all more for solids, less for liquids, means there is a physical obstruction like esophageal carcinoma or a stricture. Solids equal to liquids, or for that matter, liquids more than solids. That is a clue to say that it is a neuromuscular dysfunction associated with the motility of the esophagus, like diffuse esophageal spasm, echolalia, cardia, etc. So you will do barium swallow, which will show bird beak appearance. Bird beak appearance is what you need to remember. So what is dysphagia lusoria, doctor?
Compression caused by aneurysm of aorta.
So it is the aberrant blood vessels
Bent. Okay.
which lead to compression,
Compression.
leading to dysphagia, lusoria is what.
Lusoria.
A 40-year-old female presented with dysphagia to both liquids and solids and regurgitation for 3 months. Dysphagia non-progressive. What is your diagnosis?
Both for liquids and achalasia, sir.
So it is achalasia cardia. Now, what are the most common site for peripheral aneurysm?
It is the peripheral, popliteal artery.
Popliteal artery. Hunterian ligature operation is performed for,
Aneurysms.
so it is for the aneurysms. Nicoldoni Brahmani sign. Nicoldoni Brahmani, all Italian fellows, is also known as Branham sign. So Nicoladoni Branham. Typically, it is seen in arteriovenous fistula. It is seen in arteriovenous fistulas. So, when you apply pressure to an artery proximal to a AV fistula, then there is a swelling that reduces in size, bruit disappears, blood pressure rises, pulse rate and heart rate return to normal. So, whenever you have a high output failure with chest pain, then you want to know whether that high cardiac output failure is because of AV fistula. To identify AV fistula, you will be doing Nicolodani Branham sign is what you need to remember. I leave the literature for you. Now, this is one of the favorite questions, Doctor. Fogarty catheter. Where do we use, Doctor? Fogarty catheter?
It is removal of blood clots from the arteries.
It is for the removal of the blood clots from the arteries. Now, with regard to femoral artery cannulation, what is not true?
Single wall puncture is indicated in those with normal coagulation profile.
Correct. So, common femoral artery is cannulated. Femoral artery is catheterized at the medial third of the femoral head. Seldinger technique is used for both femoral artery and femoral vein, but single wall puncture is contraindicated because it increases the risk of bleeding and hematoma formation. Now, coming to BPH, which is not used as a irrigant during the transurethral resection of prostate, Doctor.
Normal saline.
So, in fact, all of them are considered to be safe. Distilled water is used as an irrigant during TURP. It is used to clear the surgical field, and to be precisely correct, there is no answer in this. TURP is done in an old patient of BPH, after which he developed altered sensorium. Favorite question.
Hyponatremia.
So it is the hyponatremia that develops because of using hyperosmotic fluids to do the irrigation during the TURP procedure. So hyponatremia presents anyway with altered sensorium, nausea, vomiting, seizures, even coma also is what you need to remember. Now, doctor, a patient with BPH underwent TURP, spinal anesthesia, altered sensorium. Immediately answer is?
Water intoxication. Water, IV fluid intoxication.
Then 60 irrigating fluid, not IV fluid,
Irrigating. Irrigating. Yes, sir.
60-year-old male undergoes TURP. After 3 days, develop altered sensorium. So once more, hyponatremia.
Hyponatremia.
Most important indication for surgery in a case of BPH is?
Bilateral hydronephrosis.
Very good. So, of all these things, it is the bilateral hydronephrosis. If it developed means it is very significant and you need to operate it. So, Try to remember all the indications for surgery in BPH, doctor. Any acute urinary retention, chronic urinary retention, refractory, LUTS.
UTI.
So,
Loops.
bladder outlet obstruction, then large prostate volume is very large and it is causing obstruction, then that is also an indication for surgery. Now, 60-year-old male with poor stream of urine, post-void residual volume is 400 ml, bilateral hydronephrosis, prostate is weighing 70 grams, urea is 120, creatinine 3.5. What is the best next step, doctor?
Firstly, we have to catheterize her with Foley.
Correct. So first catheterize with Foley
Foley.
catheter and then try to provide a way by which urine is being stunted out. Now, carcinoma pancreas. You know what is ominous thing about carcinoma pancreas? This dirty fellow does not declare till the last moment. Till the last moment. So that is common thing between carcinoma pancreas and Dr. Murli Bharadwaj classes. What time we are going to start will not be told. Just you are about to sleep, we will start the classes. So carcinoma pancreas also a lot of times 76, 77. Patient will be telling, "Ayyo, doctor, 1 month before only I had big plans to go around the world tour. Suddenly I am being lot of itching sensation and found to be diagnosed with carcinoma pancreas." Sudden declaration, right? So 55-year-old male, obstructive jaundice, weight loss of 7 kgs, CBD is dilated till the lower end and the main pancreatic duct is also dilated. So you should know, right hepatic duct, left hepatic duct together form along with
Com-
pancreatic
common
duct,
common bile
pancreatic
duct.
will form common bile duct. And into this will come the cystic duct from the gallbladder. So this structure you need to have clarity, doctor, for the tomorrow's exam. So
So
once more,
left and right hepatic combine to form hepatic duct,
with the
cystic
pancreatic duct to
joints,
form, I
bile
mean,
duct.
right form common hepatic duct that combines with pancreatic duct to form common bile duct, and that in turn will go and
Open at
open into the
second
ample
part
of
of the urine, ample of water.
absolutely. So good to see 10 online classmates. Please don't forget www.scoreapp.in. So if you can go to this site, uh, you have all these discussions made available, doctor. Whatever that is there in the Score Learning app is also made available. So you get for a very affordable subscription with all PowerPoints, everything. So please do subscribe. There are two courses. Uh, so there are two courses available in this. One is AIMS INICET. So where I am posting the link for you to go there. And if you already subscribed to our program, you get this free, right? Already subscribed to our learning app on the Android and Play Store. Web also is being now given freely. But if you have not yet to anything, please do subscribe to at least one of them and you get access to everything. So, doctor, let's make the great beginning. Uh, Now, it is periampular carcinoma. See, this is called double duct sign. One is pancreatic duct dilated, other is CBD is also dilated. So together getting dilated is double duct sign. When do you get? You get it in periampullary. What is periampullary? If you look at the
Around the
duodenum,
ampoule of water.
correct. So this is the point into the second part of the duodenum, the CBD and also pancreatic duct, both of them are draining. So here, if there is any ampullary carcinoma, it will cause the dilatation of both the CBD and also the
Pancreatic
pancreatic.
duct.
Together become dilated, which is called double duct sign, is what you need to remember. Now, which is not elevated in a child presenting with jaundice, icterus, pruritus, and clay-colored stool.
Clay colored stool, matlab biliary obstruction, sir.
Right. So that means gamma glutamyl transpeptidase, then 5-nucleotidase, alkaline phosphatase. They're all the important things that are elevated whenever there is any obstructive pathology, is what you have to emphatically remember for the tomorrow's exam, doctor. Yes. Now, with regard to pancreatic carcinoma, what is not true, doctor? So, hereditary pancreatitis significantly increase the risk. There is an entity called calcific hereditary chronic pancreatitis. In that, typically it is more common in Kerala among the coconut eaters, right? Hereditary calcific pancreatitis. Median survival in locally advanced disease is 3 to 6 months. They're all the true statements. It is not the P53, it is the KRAS mutation, which you see with hereditary pancreatitis. Now, which is not true about mucinous cystadenoma. They're all macrocystic adenomas, not
Not micro.
microcystic. They are lined by columnar epithelium, they are pre-malignant, and there is a focus on ovarian
Ovarian
stroma.
stroma.
Now, which is not elevated with jaundice, icterus, pruritus, just before we
Glutamate
said.
dehydrogenase.
So, 5-nucleotidase, alkaline phosphatase, gamma glutamyl transpeptidase, all of them are elevated,
Elevated.
is what you have to remember. So, good to see 9 online classmates, doctor. Very good. So, now, most common site of cholangiocarcinoma,
Hilum, sir.
hilum. Risk factor for cholangiocarcinoma,
All except stones, colloidal
lithiasis.
stones in the bile duct, yeah.
So ulcerative colitis, parasitic infestations, typhoid. So you should know the hell of list of things that can lead to cholangiocarcinoma. Primary sclerosing cholangitis, whenever you are having ulcerative colitis like inflammatory bowel disease, that can lead to autoimmune injury leading to primary sclerosing cholangitis. Chronic bile duct inflammation, hepatolithiasis, exposure to toxins, age and gender, inflammatory bowel disease, genetic factors like Lynch syndrome, BRCA2 is what you need to remember. Now, what is the most common site of cholangiocarcinoma? Once more, hilum.
Hilum.
So many times it was asked, 2011 also. A patient has surgical cause of obstructive jaundice. He is advised ultrasound. What do you see in ultrasound in obstructive jaundice, doctor? First,
Obstruct.
CBD,
Yeah.
common bile duct dilatation. Then gallbladder stones can cause obstructive jaundice.
Ascites
Obstructive
can
jaundice
be seen.
can lead to the development of biliary
Portal
cirrhosis and lead to ascites.
ascites.
And so these are the things that you see. Ultrasound cannot pick up the peritoneal mets that clearly, basically. Now comes, doctor, one MCQ on
Liver
Kynod
classification. Liver
classification.
segmentation.
So master Kynod classification, get a top rank in INICET and let us go to Wayanad for vacation. right? Now, in Kyanad classification, segment 4A of the liver is
Quadrate.
very good. So, doctor, you should remember this very important. 1 quadrate, 4A quadrate, 4B quadrate low proper, 2 left lateral, 3 left medial, 5 anterior segment of right lobe, 6 posterior segment of right lobe, 7 posterior segment of right lobe. So you need to buttify this. Then you have the branches of the portal vein hepatic artery supplying caudate. Portal vein and hepatic artery even caudate lobe proper. Then right portal vein and hepatic artery, it is the posterior segment of the right lobe. This is another thing they will ask. Caudate process may what is the bile drainage? Right hepatic duct. Quadrate lobe may it is left hepatic duct. Caudate lobe proper may both right and left hepatic duct. Left lateral may left hepatic duct. Left medial may left hepatic duct. Anterior segment may right hepatic duct. Posterior segment of the right lobe, right hepatic duct. Life is miserable. So, but still, doctor, we all mugged it. We want you to mug it. Then only you will get a seat. Otherwise, kumari rahi jayenge, right? So, forever you will remain MBBS only, right? So, we need to grow above that stage, doctor. So, right hepatic duct drains all except
Except third segment. Third is left.
third segment 3. Segment 3 is
Left
left
medial
medial.
segment.
Left medial is left hepatic. Once more, you know left hepatic duct is left medial, but if you don't know left medial is 3, Satyanash. So that is another pain. Now, coming to hepatic duct. So, right hepatic duct forms 5th and 8th, left hepatic duct forms 4th segment, left hepatic duct formed in umbilical fissure.
Fissure. Caudate drains in both. Caudate drain
lobe
proper.
into both right and
Left hepatic ducts.
left hepatic duct. So, in our good olden days, doctor, scandium, titanium, vanadium, chromium, manganese, ferrous, cobalt, nickel, copper, zinc. Like a epileptic seizure, we need to tell all the transition group elements, right? Because our classmates used to be double competitive. So all 108 elements without seeing table we used to tell. Today kids, I'm teaching my 9th class son, बकवास है pops. ये तो पेपर में रहता है. पेपर में रहने वाले को क्यों बट्टी मारना? Right? He still don't know what is medical college. Right? पेपर में भी होने के बाद भी रट्टा मार के एग्जाम को जाके you need to clear the exam. That is a whole misery. All right, doc. So, yes. Now, we'll finish by another 10 minutes. Huh? So, tomorrow we'll try to start a little early, doctor. Are you okay with that?
Yes, sir.
Good. So, now, yes. Caudate lobe drains both right and left hepatic,
Left.
which is not a liver capsular plate, another boring stuff. Portal plate. Portal plate is not considered liver capsular plate. It is a structure located in the hilum of the liver. It consists of portal vein, hepatic artery, and bile duct.
Bile duct.
The liver is surrounded by a fibrous capsule, and this capsule is divided into several plates. What are those several plates? Right and left triangular ligament, coronary ligament, falciform ligament. All these ligaments are considered liver's capsular plates, not the portal plate, is what you have to remember. Now comes undescended testis to torque. What is the ideal age for doing orchidopexy, where you descend down that undescended testis and put it back into the scrotal pouch?
1 year of age.
By 1 year of age. Orchidopexy for cryptorchidism is done 1 to 2 years.
Two
These are
years.
all true about cryptorchidism. Even after you do orchidopexy, you won't eliminate the risk of malignancy. Still, malignancy can develop even after doing orchidopexy in an undescended testis. Contralateral testis is also at risk. Seminoma is the most common tumor developing in a
Tumor.
cryptorchid testis. Cryptorchidism is a risk factor for testicular tumor.
Tumor.
Orchidopexy is done at 1 to 2 years.
1 to 2
Routine
years.
investigation used to confirm anorchia, that there is no testis at all. It is the laparoscopy is what you
Proscopy.
need to know. 50-year-old alcoholic smoker, interscapular pain, all peripheral pulses are equal, breath sounds are decreased at the left lung lobe and left pleural effusion, acute aortic dissection. So in this, even mediastinal widening will be there, is what you have to remember for the tomorrow's exam, doctor. S. Kumar is asking a leading question. Post-herpetic neuralgia, is it gabapentin or amitriptyline? Beautiful question. Amitriptyline is what? Tricyclic antidepressant.
Antidepressant.
जो ट्राइसाइक्लिक एंटीडिप्रेसेंट क्या दिक्कत होता है? It is anticholinergic. That's the reason if it is an elderly person who has a bladder outlet obstruction due to prostatomegaly, he also got herpes zoster, then bladder outlet obstruction become worsened. So the anticholinergic effects of this tricyclic antidepressant, amitriptyline, are disgusting effects. That is gabapentin. Gabapentin is acting on the GABA receptors and taking care of the pain. Maximum gabapentin problem क्या होता है? Sedation. So that is the reason gabapentin is a preferred one than the amitriptyline, is what we need to basically remember. So, doctor, that is the story. Now, after doing a graft repair of a thoracoabdominal aneurysm, patient developed weakness in both the legs. इसके पहले भी मैंने आपको ये बताया. What is your answer, doctor? What is the reason for the development of paraplegia? If you happen to do bronchoscopic embolization of the bronchial artery whenever there is any hemoptysis, मैंने तब भी बोला आपको, Adam's Cubics artery of
Injury. So, supplies
Adam's
anterior
Cubics.
segment of the spine.
Correct.
In bronchial
So
artery,
it's the anterior part of the spinal
obstruction.
cord where your anterior horn cells are located. That's the reason post-procedure there is a risk. So arteria radicularis magna is the other name for arterio. Adam's
Adam
cubics
Cubis.
is what you need to remember. Adam cubics. Now, due to deceleration, aorta can be ruptured at places where it is fixed. So what are all those places where it is fixed, where it can get injured, doctor?
Except crura. Except crura
Aortic
of
valve
diaphragms.
there is crura of diaphragm behind the esophagus, ligamentum arteriosum. In all these places, it is fixed, is what you need to remember.
Most common is that ligamentum arteriosum.
Correct. And mortality rate of emergency operation in abdominal aortic aneurysm is 20%. ये तो मारवाड़ी सेठ का परसेंटेज है, आपके हाथ में भी नहीं है. Bladder cancer is the next favorite topic. Intravesical therapy, what is the best for superficial bladder cancer, doc?
BCG.
Any day, BCG. Intravesical BCG. BCG is a vaccine, but it is also used as a chemotherapeutic agent. In a survey, many children are examined and found to have urogenital abnormalities. Which one is associated with bladder carcinoma?
Bladder extrophy.
Exot of the bladder, there is a risk. It's a rare congenital anomaly, bladder exotrophy. Typically, the bladder fails to form properly, leading to exposed and inverted bladder mucosa. there's an increased risk of bladder carcinoma because of the chronic inflammation and irritation of the bladder mucosa, is what you need to remember. So, smoking can be associated with
All
all these cancers, in fact, larynx, nasopharynx, esophagus, and larynx,
bladder.
nasopharynx, esophagus, even bladder also. One of my friend used to get a stupid doubt. अरे स्मोक करे तो ऊपर जाता ना रे ब्लैडर को कैसे जाएगा अरे तो स्मोक करे तो कार्सिनोजन है रे वो आपके अंदर जाके ब्लैडर का कैंसर लाएगा not that smoke will go into your bladder so always he used to have he's a ENT surgeon later ENT surgeon whenever we meet in party अरे क्या रे smoke कर रहे क्या bladder cancer आएगा बेटा so that's a so doctor very good S Kumar convinced with the amitriptyline answer amma I should be very careful S Kumar ka answer nahi kare to unsound mind come on sir go and get a sound mind good thank you actually you inspired me to once more prepare and spend time with you guys doctor so thanks keep reminding me whenever I forget to take a class last few questions for the today's evening another 4 minutes doctor 60-year-old chronic smoker, painless gross hematuria of 1 day duration. What is the cause of hematuria? So typically, the bladder.
Painless.
So,
Anytime painless hematuria is bladder cancer.
So any elderly person smoking history, painless gross hematuria. Unless proven otherwise, it is considered to be bladder cancer.
Carcinoma
Doubt
bladder,
it.
yes.
So urine microscopy. Then about brachial anomaly. So typically it is the second brachial remnant, which is the most common location, is what you need to remember. So basically, if you look at the other things, sinuses are more common than cysts. Surgery is usually indicated for sinuses because of the risk of recurrent infection and potential development of abscess. Whenever there is a branchial cyst, how does it present? Painless, slowly enlarging mass in the lateral neck and not associated with dysphagia or hoarseness of voice.
Hoarseness.
With regard to the branchial cyst,
mostly arises from second brachial system.
Second branchial. So all these कैसे होता ना उसके एम्स INICET क्वेश्चन बैंक में डिट्टो निकल के आके बैठेगा आपके कल के एग्जाम में. So that time the guy who solved the PYQs is the winner. Simple, right? Sir, can we please discuss pharmacology PYQs after completing surgery? Very good request. Actually, my goal is INICET 2022 दो क्वेश्चन पेपर्स है वो खत्म करूंगा. Another 3 to 4 papers between 2016 to 22 अपलोड नहीं हुआ scoreapp.in में, वो भी जरा खत्म करेंगे. इतने में एग्जाम आएगा. टाइम है तो फार्माकोलॉजी करेंगे मेगा स्वना, बट अदरवाइज फार्माकोलॉजी वेरी वेल डिस्कस्ड कंटेंट इज देयर इन द रेगुलर ऐप. उसमें फटाफट रिवीजन करो, राइट? सो लास्ट मोमेंट में दैट्स व्हाट आई एम सेइंग. INICET is an example for the upcoming next INICET and NEET PG. How do you do every 4-5 hours one revision, right? Before the exam. You are able to do means you are ready for the exam. Please let me be honest with you, right? So that's the reason time management is something that should get a practice from this INICET exam, doctor. Now the November में they are going to come with next exam 520 MCQs. 3 दिन जाके युद्ध करना पड़ता जैसे कुरुक्षेत्र. 3 दिन you need to have energy to go and fight 540 180 into 3 days. Oh my God, miserable. So be well prepared for that, doctor. Now, brachial anomaly. Now, next comes carcinoma gallbladder. These are all the risk factors of the carcinoma gallbladder.
Except
Cholelocalcis,
OCPs.
typhoid, even adenomatous gallbladder polyps, not the OCPs. So please don't forget all the risk factors. Gallstones, age, female gender, ethnicity, obesity, chronic inflammation, cholecystitis, choledocalcis, adenomatous polyps, porcelain gallbladder also, even though it is asymptomatic, if you find a porcelain, white, radio opaque gallbladder, you need to do cholecystectomy because it can become malignant, is what you need
Carcinoma.
to remember. Similarly, which organism is associated with the fish consumption and also causes carcinoma gallbladder ducted? Clonorchis sinus.
Clonorchis.
Survival in an unresectable gallbladder carcinoma, very difficult to. This kind of questions are all just stupid questions. 4 to 6 months. Organism associated with fish consumption also causing carcinoma gallbladder is Clonorchis sinuses.
Clonorchis.
So generally, Clonorchis sinuses is more often associated with cholangiocarcinoma. Bile duct carcinoma, it is more common. Of course, you can also consider gallbladder carcinoma. Coming to congenital diaphragmatic hernia. If you do prenatal ultrasound, doctor, you can be able to identify peristalsis
Peristalsis in
because
thoracic cavities.
of the gut will go
Herniated.
into the
Yeah.
there you can see peristalsis. Most common site of Morgagni, right
Morgagni
anterior.
is right anterior, sir. Ram.
Hey
Yeah.
Ram, you need to remember right anterior is Morgagni. Most important prognostic factor in congenital diaphragmatic hernia, if it occur very
Pulmonary
early,
hypertension.
it lead to pulmonary
Hypertension.
aplasia, and that lead to hypoxia in the alveoli, that lead to pulmonary capillary vasoconstriction, leading to pulmonary hypertension. So Morgagni hernia, RAM is what you need to remember. Fibroadenoma, 14-year-old healthy girl of normal height, weight, and weight for age. Her left breast, since the onset of puberty at the age of 12, it developed twice the size. Both breasts have similar consistency, normal nipples. The most likely cause is, what is the answer?
Hypertrophy. Virginal hypertrophy.
Marginal
No,
hypertrophy.
hypertrophy.
A blood stain discharge from nipple indicate
Uh, blood stain.
ductal
Green.
papilloma.
Ductal.
Ductal.
Greenish discharge.
Huh? A blood stained is ductal
Ductal
papilloma.
papilloma.
And
Ectasia is green.
fibroadenoma is called breast mouse.
Yes,
It is
sir.
very difficult to catch the fibroadenoma. You have to ask the patient, catch it and show me. Instead, you start catching, trying to do, she will slap and say, this doctor is molesting me. Right? So be careful about it. I mean, quite a few occasions it happened to the medical students. That's the reason always the rule. Whenever you have a female patient, you need to have a female nurse on the side of
Yeah.
you. Otherwise, it is a big trouble game. Which person responds how you don't know. And some patients they start a consensual approach. If you are a guy missing the standards, then you fall in trap, and later you lose your professional degree for molesting a patient. So being careful about all these ethics. Unfortunately, they don't teach in the medical college. We have to learn very hard all these rules. Now, 25-year-old lady, spontaneous nipple discharge, 3 months duration, discharge is bloody, and from a single duct. So, how do you
Ductal
manage?
papilloma. You don't do a
So,
radical duct excision. So
correct.
just same.
So, galactogram, though useful, not needed. Majority of the blood-stained discharges are papillomas. A woman noticed mass in her left breast with bloody discharge. It revealed ductectasia. How do you want to treat? So typically removing
Hadfield.
along with the duct is called Hadfield
Hadfield.
operation. is what
operation.
we need to remember. So once more, to all of you, thank you having had joined this wonderful evening with Dr. Murli Bharadwaj. रोज मिलेंगे रोज पढ़ेंगे एक दिन कामयाब बनके दुनिया को बताएंगे मेरा नंबर आ गया. Right? I'm waiting for all that, doctor. Keep away all the temptations, parties, birthdays, they all wait for you. After all, you have no contribution in the birth of somebody's birthday celebrating, right? So, if your fiancé say is having birthday, tell your fiance's papa and mama to celebrate, not you. You tell, for this time, let me crack the NEET PG. Good night, doctor. Tomorrow we'll once more
Good
meet.
night, sir. Yes, sir.